Good evening, everyone. So today we are just going to discuss the forgotten art and science of cardiac radiography. Now, this is all what we are going to see or read in a basic cardiac X-ray. And this is one of the composite images where everything has been summarized in just a single image. So let's see, whenever you are reading a chest X-ray. So we'll start with the basics, that what should be an approach of reading a chest X-ray. The reading of a chest X-ray should always follow a systematic approach. And the systematic approach just clarified as A, B, C, D, E, F, G, H as an approach. So first thing would be assessment of the quality of X-ray. And for that, either you can use a mnemonic Pier or Wright. That is, P stands for position. Now, is this a supine film? Is it an AP film, PA film, or a lateral film? Then you see the inspiration, whether this is an inspiratory film or expiratory film. You count the posterior and the anterior ribs. Then you see the exposure, whether it's overexposed or underexposed. And last of all is rotation, whether it's rotated to the right or left. Then we come to the bones and soft tissues. Sees the cardiac margins. Then you see the diaphragm. Look for the effusions or the extrathoracic soft tissues. Then the fields, that is the lung fields, the fissures, the horizontal and the oblique fissures if they are visible, and the foreign bodies if they are present. G stands for great vessels and the gastric bubble. Now, gastric bubble is an important point in making this a diagnosis for situs. That will deal later on. And then we look for hyla and mediastinum. So this is what we go from A to H. This is the approach. And this is what one has to even follow even in your exams or whenever you're interpreting an X-ray in your routine practice. So this is the systematic approach. Never go haphazard that once you just describe the X-ray, you just start with the quality of the X-ray and then directly you reach to lung fields or directly, any opacity which appears as an abnormal. Never do that approach. Always follow a systematic approach, and that is the easiest way out even in your exams whenever you're given to describe an X-ray. So first thing would be the basis of technical quality, and this is the most important because whenever you are going to analyze an X-ray, if the quality of the X-ray is not right, you should not comment further on what opacities or abnormalities are there. So in exam, if you're given an X-ray and the quality of the X-ray is not fine, just mention to the examiner that, okay, this is a rightward rotated X-ray film or a poor inspiratory film, or it's a underexposed or an overexposed film. So you should always mention this before you go on describing any abnormality in the X-ray. So we have four things to look at the technical quality. First would be the rotation, then would be the inspiration, then would be the projection and the exposure. The mnemonic is right. So first thing would be rotation. The first and foremost thing to be described is rotation, whether the X-ray is normal or whether it is a rotated film. Now, how do you see the rotation? You just see the medial end of the clavicle and the spinous process of the vertebrae. So here you can see clearly the spinous process of this vertebrae, and the spinous process of the vertebrae. Normally, when the film is not rotated, the distance between the medial end of the clavicle and the spinous process on both the sides is equidistant. So this should be equidistant on either sides. So medial end of both clavicles should be equidistant from the spinous process of vertebral body projected between the clavicles. This is the normal rotation. There is no rotation is present. Now, whenever there is rotation, why we are more concerned about it? Because towards the side of the rotation, suppose the X-ray is rotated towards the right side, on that side, there will be increase in blackness, that is radiolucency on the hemithorax. On the side to which the patient is rotated, whether the X-ray is PA or AP. So irrespective of the AP or PA film, whatever is the side of the rotation, there will be radiolucency. So you cannot comment on the opacities, whether this area is hyperinflated or the other area will be an abnormal appearing. So first and foremost, you determine the rotation. A simple trick to how do you say that whether it is right rotated or left rotated? This is the spinous process and this is the medial end of the clavicle. So towards the side, which is the smallest distance, always there is an opposite side rotation, or wherever there is a farthest distance, that is from the medial end of the clavicle to the spinous process. See, this distance is large, so the rotation is towards on the left side. So this is a very good simple trick that just measure the distance, and whatever the distance appears to be larger, it is rotation on the same side, or wherever distance is smaller, it is rotation on the opposite side. Now here you can see the left upper zone and the right upper zone. There is a marked distinction between that. This appears to be more radiolucent. This appears to be more or less radiolucent. So since this was a normal X-ray, still, because of rotation, on the side of the rotation, there is increased radiolucency. Same here. Now here, this end distance is less, this distance is more. So the rotation is on the right side. So this is the easiest way out. Even if in exams you are going to describe or we get given an X-ray that, okay, which is the side rotation is there, just follow this easier principle. You will never confuse on the rotation side. So always the greater the distance, the rotation is towards the same side. So that is very important. So then the impact of the rotation. Now, why we are so much worried about the rotation? The biggest worry about rotation is because your apparent cardiomegaly. So here you see, this is the X-ray which is taken in the PA view. That is, the images are being projected from the back and on a film. So the heart is rotated. That is, you have a left-sided rotation. So rotation, the patient rotates on the left side. So from the back, the projections are there. So there is an apparent cardiomegaly. Normally, if it had been in the center, so till here only the X-ray of the heart will be projected. But here the beam widening is there and there is an apparent cardiomegaly. So on the left-sided rotation, there is always an apparent cardiomegaly. The heart appears enlarged and the pulmonary bay, that is the main pulmonary artery and its branches, they become more prominent. So a left side rotation is associated with a cardiomegaly and a pulmonary bay which is enlarged. A right-sided rotation always leads to an underestimation of the cardiac size. So there is less amount of beam is passing towards the cardiac shadow. So your heart size appears to be pseudo in a smaller size and the ascending aorta becomes more prominent. So you can make a diagnosis of an ascending aortic aneurysm. It's a false diagnosis can be made based on this rotation. So this is very important, that why we need to have a rotation in the X-ray. Once you have confirmed that, okay, the X-ray, there is no rotation, next you should always comment on the inspiration. So in exam, you will always be given to count out the rib spaces or the ribs. That is, either you can count the anterior ends of the ribs, which are the broad end. So the ribs generally in a PA view, the ribs will follow from the spinous process to anteriorly. So this is the first rib. This is the anterior end of the second rib. This is the anterior end of the third rib. This is the anterior end of the fourth rib. This is the fifth rib, sixth rib. So these are the anterior ends. Whatever ends anteriorly, and there is space out here because there is a costal cartilage. So this is an anterior end. So you can count the anterior end of the ribs from 1, 2, 3, 4, 5, 6. Or you can count the posterior end. That is from the spinous process, posterior margin. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So whatever which is appearing more towards the heart, these are the posterior ends. And whatever it's appearing within the lung fields, these are the anterior ends. So this is a very easy way to remember that. Obviously, which are closer to the vertebral body or closer to the heart, these all will be the posterior end of the ribs. So you can count either anterior or posterior. So a good inspiratory film will have either 5 to 7 anterior visible or at least 8 to 10 posterior ribs. So 10 posterior and at least more than 6 ribs on an anterior film. So this is basically a requirement for calling it a good inspiratory effort. Now, poor inspiratory effort is less than 5 anterior ribs. So if the 5 anterior ribs are not visible, it's a poorly inspiratory film. Hyperinflated is more than 7 anterior ribs in the mid-clavicular line. Just 6.5, or some places mention as 6.5 anterior ribs in the mid-clavicular line, or you can always just remember as 7 ribs which are present in the mid-clavicular line. So this is a very simple way where you can count the ribs, and whenever you have counted the ribs, either anterior or posterior, you can say that inspiration. Now, why we are more worried about the inspiration? Just see this X-ray. So here you will have the first rib, the second rib, the third, and the fourth rib. So only 4 ribs are present anteriorly. So what you have an appearance that there is some amount of cardiomegaly is there. There is right lower zone haziness is there. The same person was asked to take a deep inspiration, and you can see a 1, 2, 3, 4, 5, 6. So 6 ribs are coming anteriorly, and this opacity disappears. The cardiac size becomes normal. Again, the left lower zone opacity also disappears. So this is very important. The same person was diagnosed initially as a case of bilateral lower zone pneumonia or a lower zone haziness with apparent cardiomegaly or with cardiomegaly, and the same X-ray if it was repeated. So this is coming out to be normal. So exams also, sometimes you are given the spotters, you are given the same X-ray, and then you are asked that, okay, what could be the possibility, and then you keep on describing this is the differential and that is the differential without looking at whether it's an inspiratory film or an expiratory film and what is the degree of inspiration. So this is very important. So mediastinal widening, apparent cardiomegaly, and bilateral zone haziness, that disappears on a normal inspiratory film. So one should be very careful when you are interpreting these X-rays. Next is the projection of the X-ray. So you have to always describe in your exams also that whether the X-ray is an AP view or a PA view. mostly in a critical care setup, whatever X-rays, if they're given, or if you're taken, given some critical care, or like an X-ray from the CCU or from the ICU, you'll always have an AP projection because the patient is critically ill, patient cannot stand, patient cannot face the plates. The plates are just kept below the body of the patient, and the images are protected from the anterior aspect. So that is an AP projection. So that's the direction of X-ray projection from front. That is called as an AP projection. If the direction of X-ray projection is from behind, that is from the back, the X-rays are going and the film or the plate is placed anteriorly close to your sternum or chest, that's the PA projection. So this is the basics. So which view to use for cardiac evaluation, PA or AP? PA is preferred for cardiac evaluation. You know why? Because heart is placed anteriorly. So whenever you are having a AP view, there is an apparent cardiomegaly. Why? Because there is an image magnification. So when you have a PA view, image is without magnification and gives the real cardiac size. So apparent cardiomegaly is very problem with AP views, and especially when you are evaluating patients in a critical care setup. So whenever never comment on cardiomegaly whenever you are evaluating an X-ray in a critical care setup, especially you are given a PA film. So that is a very important point when you are given a PA film rather than an AP film. Now, one important point more to be added always, how do you evaluate for a PA view or whether it's an AP view? So how do you say? Two basic rules are there. Now, if you are having a PA view, the edges of the scapula, that is the medial edges of the scapula, are out of the lung field. So they should not be there within the lung fields. So they're out of the lung fields as compared to AP view where these are within the lung field. So all the AP views, the scapular edges are within the lung fields. First thing, the clavicle is more horizontal in a PA view as compared to an AP view. Clavicles are more oblique in an AP view. So the edges of scapula retracted laterally with a small portion projected over each lung. So lungs fields, you can easily visualize the lung fields clearly in a PA view, and there is no cardiomegaly. The cardiothoracic ratio in a normal individual will be less than 50%. So cardiothoracic ratio is clearly well within the normal limit of 50%. This is basically a description of a PA view. While on the AP view, what you have is a cardiomegaly, which seems like CT ratio is more than 50%, and the edges of scapula are within the lung fields, and the clavicles are always they are obliquely placed with an acute angle of the ribs. So simple example, this is an AP view, and this is a PA view. Just look into the edges of the clavicle. The clavicles are within the lung fields. As compared to this, the clavicles are out of the lung fields. They are not. The lung fields are clear. First, second would be the scapula. Sorry, the clavicles are more oblique, where here the clavicles are more horizontal. The scapula is out of the lung fields, within the lung fields, and out of the lung field. And the clavicles are more oblique. The clavicles are more horizontal. So this is the two basic differences when you are making, and the same person when you are doing the same cardiomegaly will be present in an AP view, that will disappear in a PA view. So same in a PA view, the erect patient, the vertebral spines are more prominent, scapular clear of lung fields, clavicles are horizontal, while vertebral bodies appear more clear. The apparent cardiomegaly, scapular overlap, and the clavicles are oblique. So these are the differences. In exam, you might be asked to enunciate the differences. Someone will ask in exam what is the difference between a PA view and an AP view. So one should be clear that these are the basic differences, and one should be always whenever you're interpreting the X-rays, also just try to look. In most of the X-rays, it's just mentioned as PA and AP. If it's not mentioned, then you have to use a clinical judgment per se. Then would be the exposure. Again, the last technical quality is that you should always evaluate for the exposure. So how do you say the X-ray is normally exposed? So the normal exposure is that vertebral body should just be visible at the lower end of the cardiac shadow. That is, whenever there's a cardiac shadow within the cardiac margins, that is within the cardiac heart shadow, the vertebral body should just barely be visible. So if it's an underexposed, the vertebral bodies are not visible. Insufficient number of X-ray photons are passed through the patient to reach the film, and it is too much of white. The X-ray is very much whitish appearing. That's underexposed. If the X-ray film appears too black, too dark, then there are too many photons related to overexposure of the film. So here, these are the vertebral bodies and the vertebral spaces. The discs should be just barely visible. So here you can see the intervertebral spaces, the discs are just barely visible in the lower end. That is below the bifurcation of the trachea. So after the level of carina, just in the lower part of the cardiac field, these should be barely visible. Now, if you are seeing it here, you cannot visualize any vertebral body. You cannot visualize any intervertebral disc spaces. Where here, if you're looking, there are too many vertebral bodies. You can see all the vertebral bodies starting from up to bottom. So this is again an over-penetrated. The X-ray is looking too dark. These are all the X-rays of same individual. This is a normal penetration, and this is what is called as an under-penetrated film. So under-penetration, normal penetration, and over-penetration. So the same X-ray. So this is very important. Why? Because whenever you have an under-penetrated film, you can apparently make out that there can be some opacities, and you can falsely label those opacities as abnormal. And whether you have sometimes over penetration, you can falsely mix up consolidation, you can falsely mix up, pulmonary edema. These things can be mixed up, or even the vascularity will be very difficult to comment that you can surely label that there is low decreased vascularity. So whenever you are evaluating, suppose a congenital X-ray, and you are given a film, and it's an over penetrated film, and you say that the vascularity is very poor, or over under penetrated film, you can see that's a abundant vascularity is there. So this is again very important whenever you're doing a technical. So after you've done a technical evaluation, let's see, very important, that what are the structures in a normal X-ray which are given to you, a PA view. This is again the second important question is asked in the exam, that an examiner might give you a normal X-ray and you'd ask to describe what are the margins or what are the structures forming the cardiac margin, that is the right cardiac margin, the left cardiac margin. So this is very important. So this is what a normal, one should have this image in mind. SVC is on the uppermost aspect. Then you have the border formed by the trachea. The right border generally formed by the SVC, RA, and some amount of IVC if it appears or not. Right ventricle is never a part of a cardiac margin, that is right cardiac margin or left cardiac margin. Right ventricle never forms. So right ventricle is in the center part of the X-ray film. So it's forming a central portion of X-ray film, and so is the left atrium. So left atrium sitting right here, right ventricle is sitting right here. So right ventricle will generally form the inferior aspect, which is sitting on a diaphragm. So this is what you're not going to describe. You're just being describing the right cardiac margin, the left cardiac margin. On the left cardiac margin, generally you will have an aortic arch, the pulmonary trunk. Left atrial appendage is a part of it. So left atrium is never a part. The left auricle or the left atrial appendage is a part of the left cardiac margin, and then you will have the left ventricle and the cardiac apex. So this is the simplest explanation, or a basic what you can give in the exam for structures which are appearing in the anterior view. Same sometimes, rarely nowadays you are giving lateral view, but if there are some examiners, they might give you a lateral view of the X-ray also. So that is, you should know that how do you approach a lateral view. In a lateral view, anteriorly, this aspect is the sternum, and these are the thoracic vertebrae. So this is thoracic vertebrae, and this is the sternum. As we move from upper end of the film to the lower end of the film, the radiolucency increases. That is, the lung field becomes more darker. This is because there are more air spaces in the lower lung fields first. So this is how do you identify the anterior aspect and the posterior aspect. Then you can see, visualize the air column which is running in the center. This is basically the trachea, and this is the bifurcation in the main bronchi. Then you have the cardiac aspect or the cardiac margin. On a lateral view, you will have two ventricles which appear. One ventricle which appears anteriorly. This is basically just beneath the sternum. That is the right ventricle. So anterior aspect of a lateral view is formed by the right ventricle. Posterior aspect is formed by the left ventricle. And over the top of it shifts the left atrium, and then the pulmonary trunk. We just go on later in also with visualization by few animations that how you do see which structure is forming which view. So let's see the cardiomediastinal contour. So an exam, someone will ask you to describe. The technical term is a cardiomediastinal contour. Never write as right cardiac margin or left cardiac margin. Just mention the right cardiomediastinal contour and the left cardiomediastinal contour. So you'll have normal contours of the heart and the mediastinum on the chest X-ray. Frontal view, that is P or AP, that is the right cardiomediastinal contour. From superior to inferior aspect, you will have a right paratracheal stripe. You have arch of azygous vein. You have ascending aorta, superior vena cava, right atrium, and inferior vena cava. Most of the X-rays, you'll always be visualizing SVC, right atrium, and IVC. These might or might not be visualized, especially ascending aorta and azygous vein, arch of the azygous vein. Right paratracheal stripe is always visualized. So left cardiomediastinal contour, from superior to inferior aspect, there is a left paratracheal stripe. Then the left paratracheal stripe will include the great vessels, that is the left common carotid artery, the left subclavian artery, and the left internal jugular vein. Then there is the aortic arch plus minus the aortic nipple. There will be a pulmonary trunk. There is auricle of left ventricle, left atrial appendage, as we call it, and the left ventricle, which always form the apex. So this is the normal X-ray. Here, what you can see, the right paratracheal stripe, that is the soft tissue around the trachea on the right side and on the left side. So on the right side, it is called as right paratracheal stripe. On the left side, it is called as left paratracheal stripe. So both of them will have great vessels. Then you will have the SVC, the margin of the SVC. So SVC will cover a broad aspect, right, from the bifurcation, just up to the bifurcation of the trachea. Then you have the right atrium. Sometimes IVC may or may not be visualized in the left lower, in the right lower aspect, but mostly it's SVC and the inferior vena cava. On the left side, again, it's the left atrial stripe. This is the arch of the aorta. This is the main pulmonary artery or pulmonary trunk, what we call it. Then you have the auricle of the left atrium, and then you will have the left ventricle. Sometimes you can also have an epicardial fat or pad. On a lateral view, sometimes you're asked to describe the anterior cardiomediastinal contour. So anteriorly, as we have talked about, right ventricle and right ventricular outflow tract, that is pulmonary artery, pulmonary trunk is anteriorly on the lateral view. So superior mediastinum, great vessels, thymus, ascending aorta, right ventricular outflow tract, and right ventricle is on the anterior aspect. And on the posterior aspect, you will have left atrium, left ventricle, and IVC. So this is just the left cardiomediastinal, the left lateral views and the anterior cardiomediastinal contour. So you will have a right ventricle. This is the aspect of the right ventricle. There is the right ventricular outflow tract and pulmonary outflow tract. Then you will have the left atrium. The left ventricle forms the posterior aspect, and sometimes you also have an IVC which is draining. So this is the IVC which drains into the right ventricle. So this is the appearance on a lateral view. So just see the animation. So here you can see the SVC and the IVC. Then you have the right atrium. So SVC, right atrium, IVC will form you the right cardiomediastinal contour. Always remember, tricuspid valve is obliquely placed. The tricuspid valve is always oblique in nature. So this is a tricuspid valve which appears. Again, it will not appear on an X-ray view. Then you have the right ventricle. So the right ventricle is always in the center. And this will be the pulmonary valve. Again, pulmonary valve and right ventricle are not visualized normally, except when the valve is not been replaced. So if the pulmonary valve has been replaced by a prosthetic valve, so you can have this pulmonary valve which also is being visualized. So this is the normal position of the pulmonary valve. So from here, the pulmonary trunk arises. So this is the main pulmonary artery. So this is what it visibles. This is only what. So this is the pulmonary trunk or the main pulmonary artery. This is being visualized. Then it bifurcates into left and right. So whatever is seen on the right side, this is what is called as a right pulmonary descending pulmonary artery. So this is the RPDA, the right descending pulmonary artery. So this is the main right pulmonary artery. It bifurcates, and this which goes down. So there is one vascular structure which goes down. This is the right descending pulmonary artery. Then it is not the right pulmonary artery. It's a branch of it that is right descending pulmonary artery. On the left side, you have a left pulmonary artery. So this is the left pulmonary artery. Left atrium, as I said, that on a PA view or an AP view, left atrium is never visualized because the left atrium lies at the center. So is the mitral valve. What you are visualizing only is the left atrial appendage, which forms the part of the cardiac margin. So left atrial appendage. So this you can now visualize that left atrial appendage is the part of the cardiac margin and not left atrium proper. And just below the left atrium, we'll have the aortic valve. Below the left atrium, will have the left ventricle and the aortic valve. So aortic valve, pulmonary valve, these are in the central aspects. And later on, we'll also describe how do you identify these valves. But generally, you will have a left atrium, appendage, and the left ventricle, which forms the entire left side of the cardiomediastinal contour in the lower aspect. Then you have the ascending aorta. Sometimes ascending aorta can be seen on the right side. So here you can see the ascending aorta can be seen on the right side. Then you have the aortic arch and the aortic knuckle. So this you can now visualize that aortic arch and knuckle forms the left side, and the descending aorta. The descending aorta is never visualized as a part of the cardiac margin. It is always seen within the cardiac shadow. Whenever you have aneurysms, sometimes then it can be visualized. So you should know how this is normally appearing. This is the normal anatomy of various cardiac structures on an X-ray. So when you superimpose everything, this is how it appears. So you have the SVC. Some times the ascending aorta might be visualizable. You have right atrium, you have IVC, then you will have the arch of the aorta. This is the aortic knuckle. Then you will have the main pulmonary artery. So this is the main pulmonary artery which forms a part of it. You have left atrial appendage and the left ventricle. So this is the simplest way how you describe a normal X-ray or a normal X-ray which is given to you. Lateral cardiomediastinal contour. So and you can see the superior vena cava, you can see the inferior vena cava, and the right atrium. Then the tricuspid was the right ventricle. So as I said, that right ventricle is an anterior-most structure here. From the right ventricle, the pulmonary artery arises. So anteriorly, if you see on a lateral view, this is the sternum. They will have a right ventricle and the main pulmonary artery. Posteriorly, what you have is the left atrium. It appears the posterior aspect. and you will have the left ventricle. So left atrium and left ventricle are appearing in the posterior aspect. Right ventricle and pulmonary outflow tract are appearing on the anterior aspect. And then you can see the ascending aorta. So this is the simplified way. So right atrium generally never forms a part of the lateral cardiac margin. It's the lateral view, the posterior cardiac margin, and it's the left atrium and the left ventricle and the right ventricle and the right flow outflow tract. So this is what is called as the cardiac silhouette. So left atrial appendage, right atrium, left ventricle. So here you can see the right ventricle and the left atrium are never a part of the cardiac margin. So in the exam, never ever say that left atrium is a part of the cardiac margin, right cardiac margin, left cardiac margin. So is the right ventricle. So after doing all the normal X-ray, let's go on to how the first abnormality. That first abnormality is an enlargement of the cardiac silhouette that is basically called as cardiomegaly. And this is the first and foremost thing which is given in exam is to determine what is the cardiothoracic ratio and what is the cardiac size. So PA on a PA chest X-ray, obviously in the AP view, it's an apparent cardiomegaly. So most of the cardiomegalies are being reported only in a PA view. So PA view, a number of causes can be there for enlargement of cardiac silhouette. So cardiomegaly, the most common cause. Then there can be pericardial effusion. There can be an anterior mediastinal mass. There can be pericardial fat, and there can be an expiratory radiograph. So if you have excluded, there is no expiratory radiograph. There are 4 causes of a enlarged cardiac silhouette. On AP view, obviously it is always an enlarged cardiac silhouette. So first and foremost is cardiothoracic ratio. So cardiothoracic ratio, also called CTR, it aids in detection of enlargement of cardiac silhouette. That is most commonly from the cardiomegaly. So whenever there is cardiomegaly, your cardiothoracic ratio increases. So how do you differentiate cardiomegaly from other causes? That is basically on the basis of cardiothoracic ratio. Some say cardiothoracic ratio is a percentage. It's incorrect. It's always mentioned as a ratio because in the technical term, it's a ratio, mentioned ratio and not a percentage. So on a PA view, it is measured as the ratio of the maximum horizontal cardiac diameter to the maximum thoracic diameter, inner edge of the ribs or edge of the pleura. A normal cardiothoracic ratio is 0.42 to 0.5. A measurement less than 0.42 is usually deemed to be pathological. A measurement 0.50 is taken out to be abnormal. Somewhere, you can see as 0.55 or 55% also. Should not be measured on an AP view. So in an AP view, obviously, it appears as apparent cardiomegaly. So cardiothoracic ratio should be less than 0.55 on a PA view. So for our exams and all the things, the cardiothoracic ratio cutoff value is taken as 0.55, and this is the standard one. So always mentioned as 0.55, should be less than 0.55. In newborns, 0.6 is taken as a cutoff. So how do you measure the cardiothoracic ratio? This is the most common thing which is given into an exam. So first thing would be the maximum horizontal cardiac diameter and the maximum horizontal thoracic diameter. Now, mind you, the maximum horizontal cardiac diameter is not measured in the same plane. So first of all, you draw a vertical line from the spinous process of all the vertebra. Then you see the right cardiac margin and the left cardiac margin. So the right cardiac margin, the maximum prominence is here. So maximum outward curvature of prominence is here. From here, draw perpendicular to the central line from the spinous process. On the left cardiac margin, the maximum prominence is here. So from here, you draw perpendicular to the central margin. So that A plus B would be the maximum cardiac diameter. That is the transverse diameter of the cardiac X-ray. Now, how do you measure the thoracic diameter, maximum thoracic diameter? From the edge of the ribs. So you see wherever the maximum curvature of the ribs is there, from there, draw a horizontal line, edge to edge, from inner edge to inner edge, not outer edge. So never include this outer edge of the ribs. Always go for the inner edge of the ribs or the edge of the pleura. So this would be A plus B divided by C. That will give you a cardiac thoracic ratio. So A plus B upon C would be, this is where you should measure a cardiothoracic ratio, and that is what is being examined in exams also. So sometimes your cardiac thoracic ratio is more than 50%, but heart is normal. So spurious causes can be there because of portable AP film, okay, obesity, pregnancy, pericardial fat, ascites, straight back syndrome, and pectus excavatum. So again, these are a very common question asked in exams. So X-ray heart is normal, so your normal heart, but then the CT ratio is more than 50%. What are the differentials? What are the causes? So these are the causes of that. So radiographic criteria for cardiomegaly. So for blacks and Asians, the CT ratio should be more than 0.55. The CT ratio more than 0.6 in newborn. Again, this is very important. So another quite common question, examiners will ask you, especially, the senior examiners, is that any role of a serial X-ray, like suppose you are seeing an individual today coming with a cardiothoracic ratio of 0.44, and if it is increasing over a period of time, so yes, so in any increase in transcardiac diameter more than 1.5 to 2 centimeter on a 2 consecutive radiographs taken on a short interval, this is basically says as abnormal. So this is what a serial X-ray also has. A CTR plays an important role. This was a study where they have classified as severity of cardiomegaly, but again it was for a Caucasian population, where they said that cardiothoracic ratio 0.44, below it is normal, 0.45 to 0.55 mild, and 0.55 to more than 0.55 moderate to severe cardiomegaly. Again, for Asians this is not applicable. And old age and emphysema, obviously in an emphysematous lung, the heart becomes tubular, and a transcardiac diameter more than 15 centimeter in males and 2.5 centimeter females can be taken abnormal. But again, these are rare things. Only thing you need to remember is 0.55 ratio more than in adults and 0.6 in newborns. This is about the Asians. This is what the cutoff. If someone asks you that, okay, what is the severity? So this is the only classification I got in the literature, that what is the severity of on the basis of cardiothoracic ratio. Can you classify the severity as being mild or moderate or severe cardiomegaly? So again, a very simple example: draw a vertical line, maximum cardiac diameter from the left side, on the right side, on the left side, A plus B, and the maximum thoracic diameter. So here they have just R to make the outer area. This should always be the inner area. So once you have done a cardiomegaly, that once you say that, okay, the exam, you have found out that the CT ratio is there and you have a cardiomegaly. Now, next thing the examiner wants is that, okay, which is the chamber being enlarged. So that what you are saying, that how you can say that it is a right atrial enlargement, or you can say it's a right ventricular enlargement, or left atrial enlargement, left ventricular enlargement. So this is again second most common question being asked in exams. How do you determine the chamber enlargement? So all the 4 chambers, there are some, hard points. There are some criteria. So one should remember all the criteria for enlargement. Because why we are going on a stepwise approach is because when you are dealing with systemic disease, like suppose you have a case of mitral stenosis, you always have a left atrial enlargement, then you will have later on as an RA enlargement, or a case of atrial septal defect, ASD, you will be given a case of ASD, then you'll have a simple X-ray where you have a right atrial enlargement or right ventricular enlargement, or you suppose your case, the case of hypertension or aortic stenosis, and you will have a left ventricular enlargement. So this is basically you should know that how do you identify in an X-ray, what are the criteria. So let's see first criteria for right atrial enlargement. When there are multiple criteria for one thing, always remember that this is not a very hard point for a criteria, but the easiest criteria for a right atrial enlargement is right atrial border extending more than 3 intercostal spaces. So if your right atrial border, so this is the right atrial border, if it extends for more than 3 intercostal, 1, 2, and 3. So beyond 3 intercostal spaces, any right cardiac border, if it extends, this is basically enlargement of right atria enlargement. So first criteria, and the easiest way out is right atrial border extending more than 3 intercostal spaces. Second is measurement from the mid vertical line to the maximum convexity in right more than 5 centimeter adult and more than 4. So second criteria is you again draw a vertical line from the spinous process and then a transverse line to the maximum convexity of right atrium. And if the distance is more than 5 centimeters in adults or more than 4 centimeters in children, so this is again a second criteria. Third thing is that right cardiac border become more convex, more than 50% of the right border. So again, this is a very soft criteria. So the 2 main consistent criteria are right atrial border more than 3 intercostal spaces and the distance is more than 5 centimeters. On a lateral view, fullness in the right space between sternum and upper part of the cardiac silhouette is again a criteria for a lateral view. Some examiners might ask you this. So here you can see a case. First of all, once you identify that, okay, there is cardiomegaly, the CTR ratio in any case is obviously more than 0.55. Here you can see there is this right cardiac border. So the right cardiac border, if you can see, it extends for more than 1, 2, 3, 4, 5 intercostal spaces. So it's massively enlarged. Again, you can draw a vertical line. And obviously it appears more than 5 centimeters, more than 10 centimeters appears. So this is why you can make a diagnosis. So this is the case of Epstein's. And, this right atrial border was massively enlarged. So this is what you are given in exams. And you're given sometimes a spotter, sometimes, so you are asked to identify the criteria. And then you should be very clear about the criteria for right atrial enlargement. This is another X-ray. So 1, 2, 3, up to 4. So this is the right atrial border. Or again, you can draw from here. It obviously appears more than 5 centimeters. So This criteria should always be fulfilled. So right atrial enlargement. So if someone asks you that what are the causes of right atrial enlargement, isolated. Obviously, there are other causes of right atrial enlargement, be it atrial septal defect, pulmonary hypertension. So isolated, like a person only has the right atrial enlargement. There are three causes: Epstein's anomaly, right ventricular endomyocardial fibroelastosis, and tricuspid atresia. So these are three important causes of isolated right atrial enlargement. Then second and the most important criteria for left atrial enlargement, and this is what is being commonly asked in exams, be it your postgraduate or even a specialty exams. So what are the criteria for a left atrial enlargement? First foremost criteria is widening of the carina. The carinal angle normally is 45 to 75 degrees. So if it appears more than that, then this is the first criteria being fulfilled, and widening of carinal angle. Second will be the elevator of the left bronchus. So the left main bronchus is being elevated. There is straightening of the left heart border. Then there is a double atrial shadow, that is a shadow within the shadow. There is also a classification system. So sometimes someone asks you that what is the severity of the atrial enlargement. So there is grade 1, grade 2, and grade 3. Grade 1 would be double cardiac contour. Grade 2 is when the left atrial border touches the right atrial border. And grade 3 is when the left atrial overshoots the right cardiac border. Then another criteria for left atrial enlargement is displacing the descending aorta to the left and esophagus to the right is seen in barium swallow. Distance from the right border of LA to the left bronchus being more than 7 centimeters. On a lateral film, it is focal posterior directed bulge, posterior and upward displacement of the left main bronchus. So we'll see one by one what are the criteria. Now, in an LA enlargement, normally first would be the left atrial appendage which enlarges. LA enlargement appears as the fullness beneath the PA shadow. The earliest finding of left atrial enlargement is a straight left heart border as seen in critical mitral stenosis, where MP is also enlarged. So first thing would be a left atrial appendage which gets enlarged, will become more prominent, and the thing you see on an X-ray would be a straight heart border. So a straightening of the cardiac border is the first sign of a left atrial enlargement in form of left atrial appendage which enlarges. Now LA enlargement is not necessarily proportional with left atrial enlargement, so it can be depending on what stage its presentation is there. So mostly the left atrium enlarges posteriorly, superiorly in upward direction. So if it enlarges in upward direction, superiorly and posteriorly, so the only space it can have is upper, so it can push the main bronchus above. So you will have an displacement of the left main bronchus. Whenever the left main bronchus is displaced, you will have the enlargement of the carinal angle. So the mainstem bronchi it appears widened, and then you will have the double cardiac contour. So LA can also enlarge either on the left and the right and reach the right heart border. So first it will enlarge superiorly upwards into the left. So this will lead to a widening of the carinal angle and this elevation of the left main bronchus. So first it would be earliest sign of left atrial enlargement is straightening of the left heart border. The second sign would be elevation of the left main bronchus and widening of carinal angle. The third sign would be now LA doesn't have a space to enlarge on the upper side. So now it will start enlarging towards the lower side. So it will come towards the right side and it will reach the right heart border, or it can overshoot it. So it will form a double atrial contour or a double cardiac shadow. So double cardiac shadow is the third in the course. So first it will be straightening of left heart border, earliest appearance. Then it will be the straightening or elevation of the left main bronchus and widening of carina. And the third would be, it reaches the right heart border and it forms the double atrial shadow. Now, the subcarinal angle is normally less than 75 degrees. If it becomes more than 75 or sometimes 90 degrees, it becomes very prominent. And LS can sometimes enlarge anteriorly, but anteriorly you will have right ventricle, it resists. So sometimes you can have an LA enlargement, rarely, but whenever LA is seen in mitral regurgitation, the largest left atrial diameters are seen in cases of mitral regurgitation where you have aneurysmal LA. So in that case, it can enlarge anteriorly, it can lift the right ventricle, and it can also produce a left parasternal lift, which is on a clinical examination quite prominent. Inferior enlargement is not possible in a significant way. It is limited by the AV groove and the strong fibroskeleton. So LA can never enlarge inferiorly. So it can only enlarge superiorly, upwards and left, or it can enlarge towards the right side, or rarely as an anterior. No posterior enlargement, no inferior enlargement. So here, the modes of the left atrial enlargement, if it enlarges upwards and to the left and superiorly, it will elevate the left main bronchus, it will widen the carinal angle, and it will make it more than 75 degrees. If it basically enlarges towards the right side, it will form the right heart border. Inferiorly, it doesn't. If it goes posteriorly, it will push the esophagus, because behind the LA lies the descending aorta and the esophagus. So it will push the esophagus and it will cause compression of the esophagus, and patient may report with dysphagia. So here, elevation of the left bronchus, widening of the carinal angle, and displacement of this. So first thing is the straightening of the left heart border, then the displacement of that is the double atrial shadow. This is what you double atrial shadow. This is the grade 1 double atrial shadow. This is grade 2, that it reaches the right atrial border, and the grade 3 is on the left atrial border, it goes overshoots it. So grade 1, grade 2, and grade 3. So this is a double cardiac contour or double atrial shadow you can see, and these are the elevation of left main bronchus. So here you can clearly see the two cardiac contours. One cardiac contour is continuous with this. So this is the right cardiac contour, that is the right atrium, and this is another contour beyond it. So the left atrium has enlarged and has come here. So this is basically, and there's an elevation of the left main bronchus, there's widening of the carina. So this is what you have a left atrial size, and this is the right atrium. So this is the grade 3 left atrial enlargement on an X-ray. Again, and a very important X-ray you can see here, the left atrium has enlarged towards the left side, it has enlarged towards the right side. You can see a double atrial shadow. You can see the widening of the carina. You can see a wide spaced carinal angle. You can have a left main bronchus which is elevated. So this was again a case of aneurysmal left atrium seen in case of severe mitral regurgitation. This is again, focal atrial enlargement. Here you can see one cardiac contour. This is second cardiac contour. This is the enlargement of the left atrial appendage. Now straightening beyond the straightening. So this is the earliest signs you can see on an X-ray for left atrial enlargement. So a hypertrophied left atrial appendage again appears as this way. Aneurysmal LA, when the LA enlarges to the left and right. So here you can see it has continuously completely reached up to the right cardiac margins. This is what you can see in enlargement. So everything you can see here is left atrium. So case of severe mitral regurgitation, there was widening of the carina, there is elevation of left main bronchus, and there is aneurysmal LA. So on a radiologically, when LA enlarges to the left and right and approaches within an inch of the lateral chest wall, so that is basically a criteria for aneurysmal LA on a chest X-ray. So sometimes may ask you this. So this is another X-ray. What you can see here, you can have one cardiac border here, another cardiac border. So this cardiac border, this is continuous with the right side. This cardiac border is appearing beyond this. So this is basically a grade 3 case of left atrial enlargement. Then again, the left atrial appendage also appears enlarged posteriorly here. So this was basically a young female where she had come to us with dysphagia and somewhat hoarseness of voice. And this was the X-ray. So on the basis of X-ray, we made a diagnosis that it was massive left atrial enlargement. Here you can trace the cardiac contours on the left atrium. So then we did a barium swallow. And what you can see classically on a barium swallow, the esophagus is displaced to the right side. But here you can see this is marked narrowing of the stenosis of the esophagus because of the left atrium, which is pushing the esophagus. So this is basically a classical case of patient presenting with dysphagia and Ortner syndrome. And this is aneurysmal LA. She was a case of diagnosed as a case of rheumatic heart disease, severe mitral regurgitation with aneurysmal with large size LA. So another question is being asked in your exams would be the Moguls of the heart. Now, what are the Moguls of the heart? These are basically the bulges of the cardiomediastinal contour on frontal chest X-ray. On a PA view, some bulges are seen on the X-ray on the cardiomediastinal contour, and they are basically called Moguls. So the cardiomediastinal bulges are likened to a skiing Moguls. That is bumps of packed snow on a mountainside sculptured by turning skis. So this again, someone asks you that what is a Mogul? So basically it refers to a skiing Mogul. This is basically a packed snow on a mountainside. If someone has gone for a skiing, so you can be very clear to them. Awareness of the location and etiology is very important. So you'll have various Moguls, first, second, third, fourth, fifth. So one should know what are the causes and what is the abnormality. So these are basically the Moguls. They are bumps of snow, basically with the ski tracks, and these basically are seen on an X-ray. So when they are seen on an X-ray, we call it as Mogul. So there are 5 Moguls. There's first Mogul, there's second Mogul, there's third Mogul, there's fourth Mogul, and fifth Mogul. So all the Moguls are located on the left cardiomediastinal contour. So this is always clear that one should not try to find out the Moguls of the heart on the right side. So in exam, will be asked that, okay, describe the first Mogul, the second, and third, fourth, and fifth. So first Mogul, it is the uppermost, located paratracheally above the carina and formed by the aortic arch. So this is the first Mogul, and this is basically formed by the aortic arch. So normal structure which is present in the first Mogul is the aortic arch. Now aortic arch may get prominent. So in a disease state, your first Mogul will appear as because of ectasia. So there can be an aortic ectasia or aortic aneurysm, or it can be even in hypertension. There is also a figure called figure of 3 sign or notching of the aorta, which is in coarctation of aorta, which will come on later on in our presentation. So in coarctation of aorta, you'll have a notching, which is seen in the first Mogul. So there are two abnormalities in first Mogul. First is aneurysm and hypertension, and second is the figure of 3 sign or notching. There is a second Mogul. It is located just above the left main bronchus and represents the main pulmonary artery segment. So here, this is the second Mogul, where you will have main pulmonary artery segment just above the bifurcation of the trachea. And it is excessive convexity is seen in post-stenotic pulmonary dilatation. So if you have a case of pulmonary stenosis, so there can be markedly enlarged pulmonary artery, arterial hypertension, or significant left to right shunts and pericardial disease. So if you have a very prominent second Mogul, so if it appears very convex, so these are the causes of it. Concavity suggests that right to left shunt, pulmonary atresia, or malpose. So if you have a markedly enlarged pulmonary artery, so there will be a marked convexity in the second Mogul, and these are the causes of that. If there is concavity, that instead of appearing convex, it appears as concave. This means the pulmonary artery is absent. So either there is a pulmonary atresia or right to left shunt where the pulmonary blood flow is less, and you'll have malpose grade vessels. The vessels are not properly positioned, so they are anterior and posterior. So this is again second Mogul. Third Mogul is never normal. So in all cases of heart, so if someone asks you the third Mogul, so this is always abnormal. And if it is present, it lies below the left main bronchus and usually formed by a prominent left atrial appendage, which is seen in rheumatic heart disease. So this is the third Mogul, and there is no normal structure located. So if you have a third bump on an X-ray, there is always most common causes enlarged left atrial appendage. So in an exam, you generally be given an X-ray of mitral stenosis, and they'll ask you that, okay, this is what this appears. So this is basically the third Mogul, and that is basically it is the enlarged left atrial appendage, which is commonly seen in rheumatic heart disease. Other causes include cardiac aneurysm, there is pericardial cyst, coronary artery aneurysms can be there, mediastinal tumors, pericardial defects, sinus of Valsalva aneurysm, and dilated right ventricular outflow tract. So these are again the causes. So in exam, they'll always ask you what are the causes of a third Mogul, which is very prominent, and these are the differentials. Then the fourth Mogul is the bulge over the diaphragm, and it is formed by the cardiac apex. That is very simple. Fifth Mogul is again the bulge of the cardiophrenic angle, and the causes will be prominent pericardial fat, pericardial cyst, or adenopathy. Some lymph nodes, pericardial cyst. The fourth Mogul is formed by the left ventricular apex. It is always normal. Fifth Mogul can be formed by the pericardial fat, pericardial, or there can be some tumor or sometimes even lymph nodes. So here just on X-ray, you can see a first Mogul, that is aortic knuckle. Second Mogul is a pulmonary artery segment. Then you will have a third Mogul, left atrial appendage. Then your fourth Mogul is apex. And here sometimes you can have a fourth Mogul. Sometimes even examiners will ask you what is the right-sided Mogul. So right atrium is the right-sided Mogul. That is because if you enlarged right atrium, it will always form a convexity. So after doing a left atrial enlargement criteria and right atrial enlargement criteria, let's go on to the criteria for left ventricular enlargement. So left ventricular enlargement, the criteria are very easy. Left cardiac border gets enlarged, and normally the left enlargement is always, as we have been treated even from MBBS times, it is always down and out. So down and below, left cardiac border gets enlarged and becomes more convex. It results in cardiomegaly. Left cardiac border dips into the left dome or diaphragm, so it goes below. It appears as rounded segment, duck back appearance. But the most important, the most confusing thing is the cardiophrenic angle. The cardiophrenic angle is always obtuse in a case of left ventricular enlargement. So the lateral view, it always enlarges inferior and posteriorly. There are some, measurements. Again, these are all exam based. No one, you just need to remember if someone asks you in the exam that what are the criteria. These are not being applied practically as of now. So this is how the left ventricle enlarges posteriorly. So this is the IVC, and it goes. The IVC becomes incorporated into the cardiac margin and goes beyond it. So normally IVC is lying here, but if the left ventricle enlarges, it will go posteriorly. So it enlarges posteriorly in a lateral view. RIGLER'S measurement and these all can be skipped up. Euler's ratio can be skipped because these are not important. What is more important, I'd like to ask you is that just focus on this diagram. A left ventricle always enlarges in this way towards the diaphragm. it becomes more rounded in appearance. And the angle, that is the cardiophrenic angle, the angle it makes with the diaphragm is always obtuse. So a cardiac thoracic ratio is increased and obtuse angle is made. So these are just two ways you can just differentiate a left side cardiac apex or a left LV enlargement. So here you can see this is the LV enlargement, and there's a rounding of the cardiac apex. It goes more inferiorly, and the angle you can see with the diaphragm is more an obtuse angle. Again, you can see the aspect is displaced inferiorly toward the left ventricle, and the angle it makes, this angle is more obtuse. And also you can note a double atrial shadow, and this is grade 2, it just touches the right atrium. So grade 2 left atrium, then the straightening of the left heart border, other findings. So this is a case of mitral stenosis with MS with MR. So generally you can sometimes get a combined lesion. So if you have an MS with MR, one of the X-rays, classical X-rays will be this. Then this is again a very simple X-ray. You will have double cardiac shadow. This is the two cardiac margin. There is straightening of left heart border. There is a third mogul which is very prominent. So left atrial appendage is very prominent. And then there is the left apex which is enlarged. And here you can see the angle. So this angle is obtuse. And this is the most important confusing thing, in exams. You tend to confuse, you are given a case presentation, and then when you're going to ask to present an X-ray, and then you get confused whether it's an LV apex or an RV apex on an X-ray. So an LV apex always appears as a obtuse cardiophrenic angle. And this is a very hard point. So this is not a very subjective thing, this is a very objective thing. Sometimes a subjective appearance will be that downward displacement might look subjective, but if an angle is always obtuse, it's always an LV type apex. Again, you can see the angle very clearly. The angle is obtuse. So this is again a classical example of cardiomegaly. CT has more than 0.5, and you will have a LV apex. Now right ventricle. A right ventricle, as it dilates, it expands superiorly, laterally, and posteriorly. So right ventricle is always an anterior structure. So it can never go anteriorly. So either it will go superiorly above, it will go laterally, or it will go posteriorly. So the only way a right ventricle to go is to displace the left ventricle. So classical signs of right ventricular boot-shaped heart, classically seen in tetralogy of Fallot. In RV, PA view, the apex moves posteriorly. So that is there. So RV, the cardiac apex moves posteriorly, and the right ventricle forms the left cardiac border, resulting in rounded elevated apex. So someone had a doubt that how does this form the obtuse angle? See, the angle is the cardiophrenic angle, the angle which the heart shadow which makes with the diaphragm. This is the angle, and that angle is the obtuse. So anything which is more than 90 degrees is the obtuse angle. So from the apex where it cuts the diaphragm, just measure this angle. So this angle, it appears more than 90 degrees. So it's basically an obtuse angle. If it would have been an acute angle, so whenever you're seeing an RV apex, you can just say that how an acute and obtuse is different. So just see this diagram. Here the angle, this is the angle. So if it is more than 90 degree, so that is an obtuse angle. When you see an RV apex X-ray, you will be clearly sure that what is the difference. So RV apex, the angle is acute as compared to an LV apex. So an RV apex always goes horizontally, and LV apex goes inferiorly. So there are 2 points. RV enlargement on lateral view, this is the most important question examiner asks you. How do you see a lateral view? Because obviously these days we are never tuned to see a lateral view X-ray, and the examiners know this. So they'll ask you the obliteration of retrosternal space. As I said you that RV is the anterior structure on a lateral view. So if the RV enlarges, the retrosternal space behind the sternum, whatever space is there, it will obliterate. So the contact of anterior cardiac border is more than 1/3 of the sternal length. This is the criteria for an RV enlargement on lateral view. If you just remember that this is the criteria. Euler's and ratio, RIGLER'S ratio is not being required at your level. So this is again cardiothoracic ratio, and this angle I was saying, this is the angle which is acute, less than 90 degrees. If the angle is more than 90 degrees, obtuse. So here you can see this angle, it is less than 90 degrees. So this is basically a classical example of tetralogy of Fallot, an X-ray which is right. Again, this angle less than 90 degrees. So this is basically an angle which is an acute angle, around 35-40 degrees. And this was a thing that obliteration of the retrosternal space. Normally, these black areas which is present because the lung is present. If the right ventricle enlarges, this area becomes more radio opaque, and you will have obliteration of the right this retrosternal space. Second point would be 1/3 of sternum. So sternum, the length of the sternum is from here to here. At least 1/3 of the sternum length is being in contact with the right ventricle. So these are the classical X-rays which you get in exam of retrology of fallow, and that is how you describe a RVFX and a LVFX, acute angle, obtuse angle, and the direction of enlargement. So here you can see the RV, the FX is going along the left side, so it is horizontally displayed. In an LVFX, it is obtuse and a inferiorly or downward displacement. So with that, you can clearly make out an LV versus RVFX. So sometimes, you know, apex might not be visible, and here you can say that so this is because a left atrium which just tends to occupy everything, and it might blur out your appearance of left ventricle. This is because an LA which is so much enlarged that the LV is pushed up behind, and only you can see is the left atrium. So this you might get confused that the left ventricle is not there. But if you see it very clearly on an X-ray, this is the left ventricular margin. So again, this is basically an over-penetrated film, the overexposed film. So you can have all the intervertebral spaces which are being seen. So in an exam, someone gives you this X-ray, and you say that, sir, I cannot see a LV borders. You are clear that you have evaluated the quality of the X-ray, because obviously it's an overexposed film. So everything appears, you know, these are just the intervertebral spaces are beyond visible. And here you can see this left ventricle. So one thing one should be very clear is that left ventricle, the enlargement, mostly you should know what is the pathology. Like if you are given a case of mitral stenosis and mitral regurgitation. So here you will expect it that the apex would be left ventricular apex, as compared to suppose a case of tetralogy of Fallot where you will be a right ventricular apex. So apex, if you are seeing clear out acute angle and obtuse angle and the direction of movement of the most prominent bulge, you can make it out that this is the left ventricular apex and the right ventricular apex. So